Hello, good evening everyone, and welcome to already our fourth primetime debate dedicated to how to deal with aesthetic problems in implant dentistry, including live surgery sequences. Now I'm here in Paris joined by Sofia Aroca, who is a periodontist here from Paris and appointed at the University of Bern also. Good evening, Sofia.
Good evening.
Glad that you're with us tonight. You will contribute to the session live here by sharing your surgical videos and telling us what you do. And then in comparison with what's happening in Hamburg, we will then learn as much as we can, I hope. Because this session will be run by Chair Professor Ronald Jung and his 3 experts in our studios in Hamburg. But remember, this is a Channel 1 live session. So if any time during the debate you have a question or an addition, make sure you take the opportunity to submit it straight away, and I'll relay your text to Hamburg. Now, let's hand over to our team in Hamburg. Professor Ronald Jung, good evening. When you are ready, take it away.
Good evening, Gerrit. Good evening, ladies and gentlemen. It's for me a tremendous pleasure to be here, actually for multiple reasons. Number one, I think the EAO did a tremendous job in terms of putting together these digital days. And I think we really wrote history in terms of dental education. Number two, I'm surrounded by the best surgeons and periodontists worldwide. And number three, that's more like a problem. Because I saw a patient 2 weeks ago. And she got an implant 11 years ago. And the crown looks actually pretty beautiful, I have to say, from a prosthetic point of view. I'm a prosthodontist. But she has a deficiency on the buccal aspect regarding her soft tissue in a vertical and a horizontal way. And to tell you the truth, I didn't know how to approach this. Because on the one hand, I didn't want to make it even worse than it is. So for me, the aim tonight will be to understand how I'm going to treat these patients with deficient tissues on the buccal aspect of the teeth. And I would like to know every detail. I would like to know how I'm going to do the incisions. I would like to know how I'm going to open the flap. Or maybe I do open the flap. I want to know whether I need a graft or not, where I harvest the graft, how I place the graft, and at the end, how I'm going to suture these. And these, ladies and gentlemen, that's what we're going to do tonight. And we want to know all these details. And we have the best worldwide here in order to get this information. We have 2 surgeons which did the videos. This is on the one hand, Sofia Aroca from Paris, which will be in Paris. Hello, Sofia. And we have Markus Hürzeler. He's a professor in Munich, and he has his private practice, and he's a true superstar. You can also see the shoes he's wearing. That's only superstars wear these type of shoes. And to my right, we have Martina Stefanini. She's a fantastic periodontist, a surgeon, and also a researcher from Bologna. And then we have the famous Tony Sculean. He's professor and chairman at the perio department in Bern. So you see, we have everybody ready here in order to answer this question, and I make sure that we can all answer this question which we addressed before. I would like to start now with Mark. I really want to know what is your thought and how you approach these cases when they come kind of prosthetically in a nice situation, but they have really problems on the level of the soft tissue. How do you approach these cases?
Thanks, Ronnie. I would like to start to share with you our thoughts, our philosophy, how we do today plastic reconstructive surgery in the aesthetic zone. When we in our clinic do the modified coronal positioning flap, we often end up with a situation like this. And we are very successful to cover the recession completely around teeth, but when we look into proximally, we are not so happy with the outcome. And therefore, we dedicated our time in the last years very much to this kind of surgery that we do tunneling. We avoid any cut in the aesthetic zone through the papilla, because then we would count on the wound healing capacity of our patient, and we cannot predict that. Now, since we elaborated this technique more and more, and we tried to use it also around implants, we thought we just can transfer this technique around implants. And we did this, as you see in this case. We did the tunneling. We placed an autologous connective tissue graft in there, into the tunnel. Then we placed some anchor suture interproximally. We coronally positioned the flap. And then when we look at the case, 4 years later, it was not very successful. So it became obviously for us this might be a problem. We found out that we have a problem with mobilization. And this is exactly what I want to discuss with you today. How can we achieve today enough mobilization of our flap on the buccal side without cutting in the visible aesthetic area? This is all about what I want to discuss with you. And we transfer all the cuts today to the palatal side, where the patient is not concerned about.
Thank you very much, Mark, for this short introduction. I think we got direction of how you would like to solve my problem I have with my patients. And I would like to ask Sofia. Sofia, how you approach this type of patient, which come with soft tissue deficiencies around the implants? We know implants are a difficult type of situation because we have a dead surface there. It's a different story than around teeth. How do you approach this problem in your clinical practice?
Yes, thank you, Rennie, for kicking off. Now, Sofia, you also brought a case with you, right? That we are going to follow in all the different surgery segments. So why don't you introduce the case?
Yeah, I will. If we can see the case, you can now observe that this particular case, this clinical situation, is extremely difficult. This young adult I received this young adult at the University of Bern because they received an implant on the lateral upper incisor. And you can see, as obviously, very frequently, we can also observe a clinician that next to the implant we have a recession. And particularly in this case, the recession is extremely huge, large, and touches the interproximal area. Therefore, of course, we can discuss with kind of surgical technique or about philosophy to preserve or not to preserve the papilla. But I think when you are dealing with this kind of clinical situation, complex clinical situation, there is not only one surgical technique that we can apply.
Okay, so this is the case, this is the situation. What was your plan when you went in?
I am planning to, for the situation, you can see that now I go for a submarginal incision. Why? Because I choose to go for a papilla amplification flap. Means because in this kind of situation, if you have time to see and to observe, to follow the patient, is a patient from the university. Therefore, I could not follow the patient very long. Therefore, the best way is to prepare the patient. When you do not have time, you have to deal with that. And the papilla amplification flap is I think, is one of the best techniques for that. When you are doing the soft marginal incision, as you can see here, with that you elongate the papilla. Because you elongate the papilla, and since you have a huge recession on the central incisor, you have to place a vertical releasing incision. And Mark is right, but when you pay attention how to deal with this vertical releasing incision, because it's oblique, therefore you do not go straight to the periosteum, and in that case you eliminate maybe the scars afterwards. Therefore, the important thing is to go to amplify the papilla. If you cannot grow before, modifying the crown itself in order to augment the volume of the papilla, and you can go for this solution.
Exactly. Well, thank you for introducing the case and the first live surgery sequence. We have two cases on the table, Ronnie, and we've seen the first video of a buccal incision. So I'd like to hear how you take on with that conversation.
Thank you very much, Gerrit, for that first insight about this case. I think it looks pretty controversial to what we have seen from Mark, but now I would like to go into the case from Mark, that you're going to start with your incision, how you're going to handle the incision in your case. Can we have the video?
As I said during my introduction, we would try to avoid any cuts in the visible aesthetic area. So our way is in a case like this that we start also sulcular, as you see, with a microblade. We go with a sulcular incision. We have to detach the connective tissue attachment. We need to be very, very careful to the connective tissue attachment. And then the major part of the surgery is going to take part on the palatal side, where we know today that we need to create mobilization of tissue because we need to plan or we need to bring more volume on the buccal side. And if we don't do that, by getting tissue from the palatal side, we will end up with a compromised outcome, as we have seen in our cases when we started the tunneling technique around implants. So sometimes you have to go to the neighboring teeth a little bit, but also only in a sulcular approach. And now we go to the palatal side. You see here we start with really incisions, which can create scar tissue. We all know that. If it's oblique or if it's straight perpendicular on the surface, it's very difficult to predict if we don't get scar tissue, yes or no, if it's oblique or not. I would doubt that. So we do a perpendicular incision on the surface, and we go to the palatal side, and we try to mobilize a lot of keratinized tissue, as you see, because the palatal side is completely keratinized. This allows us to not overcome or to not get into the problem with decreasing the amount of keratinized tissue on the buccal side. The connection between the two small vertical easing incisions on the palatal side is also done perpendicular on the surface, which creates at the end a so-called island flap, or this first flap was defined actually or first described in the dental literature by Carlo Tinti in 1995. So this is our outline of the flap, where we clearly can see that there is no cut on the buccal side to take any risk to have later on, in addition, more scar tissue or less quality of tissue.
So thank you very much, Mark, for these comments. I'm excited because I can really see that we have two completely different approaches. And I would like to ask my experts. On the one hand, what I've seen by Sofia, it's more an approach which looks pretty difficult to get there. Martina, why do you think it is more appropriate to go from this buccal aspect?
I think that the most important aspect is to decide the indication for the treatment, because I think that in the case that Markus showed, the gingival margin at the level of the implant-supported crown was more or less in the right position. So you don't need to really coronally advance too much the gingival margin. So in this case, I totally agree with him. You can be less invasive and perform this surgical procedure without elevating a flap. When you face a surgical defect in which you have to coronally advance the gingival margin, let's say 4 or 5 millimeters, if you don't open the papilla, if you don't elevate the flap with vertical releasing incision, I don't know how you can obtain the same result.
I can feel already the knistering on my left side. I wanted actually to go to Tony, but I think I cannot because Mark is too hot. So
No.
can you solve a problem like you have seen? Because obviously the case from Sofia is significantly more difficult from that point of view.
That's no doubt.
Can you solve that type of defect also with a tunneling technique and a palatal island flat as you showed it in your case?
Honestly, when I look at the case from Sofia, I must say I would never do the surgery at the moment, never. This is, from the beginning, in my opinion, a failure, because the papilla between the implant and the central incisor is so thin, there is no chance for adaptation with the best coronal positioning flap ever. So in my opinion, this case, you should take off first the crown. I have seen the case the first time, honestly. You all know that I haven't seen the case till today. That's the first time I saw it here. I would have taken off the crown. I would have let Mother Nature make me more tissue automatically. You don't have to do any surgery. It closes automatically. You get a lot of tissue. And then we can discuss what Martina says. Then you have a wide surface. Then you can make a coronal position flap maybe. But I'm sure I could manage this case because it's not so much. I agree, there are cases which can really be, when we speak about 5-6 millimeter, but you now announced, but this is not 5-6 millimeter in this case.
And I totally
this case, I will guarantee you, you let Mother Nature create the tissue, and then you can do it easily with a releasing technique from the palatal side, as I described a little bit at the beginning. I'm pretty sure I could solve it.
Okay, one theoretical option would be that Sofia is just a better surgeon than you.
Yeah, that's true.
But now I really want to hear Tony's opinion. You have now seen the two different cases. Obviously, the first one by Sofia is a little bit more challenging in terms of the soft tissue situation. And I would like to particularly focus on that one. How would you approach, in this case, from a flap point of view?
Yeah, I mean, the two cases are completely different. I mean, in the case of Mark, probably we are dealing with a soft tissue deficiency facially. And this is what you want mainly to augment, if I understood it well. In Sofia's case, we have also a certain loss of interproximal bone, and the papillae are very, very thin. So I think that in Sofia's case, we need to work together with a prosthodontist, because that's very important. You can be the best surgeon in the world, but if you don't have an excellent prosthodontist, you will not succeed. So you need temporaries that are prefabricated with a concave surface, and then together with some grafting procedure. And then the timing can be decided, can be discussed, should be discussed. But I think it needs a team approach. And this was also done in Bern. So the idea was to have the temporaries that will condition the soft tissue, because you cannot leave the patient without anything in that area, but we need a certain soft tissue augmentation. And of course, we have to also keep in mind that maybe we won't achieve a perfect outcome, even if everything is put together in the best way. So going back to the incision, I think it is very, I mean, in this case, a complete tunnel is very difficult, because the papillae are very, very thin, the area is very narrow, probably a high chance is there that the papilla is going to rupture. So probably I would have created a kind of envelope flap, mesially distally, extended it, but interproximally you have to relieve it. And then, of course, it is also a matter of the position of the implant. This is also very important, because this we didn't see. Because if the implant is positioned too far facially, then it is even more difficult.
So there's one aspect which I have heard out, being a prosthodontist, obviously, is taking out the crown.
Yeah.
There are two options. Either I take out the crown and make a temporary reconstruction with a little bit more narrow neck there in order to get more tissue, or to take it completely out and let it heal, as Markus has said. Would that be an option, Martina, that you would prefer to kind of take out the crown, let the soft tissue heal, and then you have kind of like an edentulous space there in order to graft that?
Yes, this is another good option, especially because of the lack of attachment of the central incisor. So in this case, I would have removed the crown, removed the abutment, placed an healing screw, and let everything heal, and then perform the so-called platform connective tissue grafting technique in order to increase occlusally and buccally with the connective tissue, and try to improve also a little bit more the interdental soft tissue, because this is the main problem.
Let me add something more. Of course, all of you are right in order to let tissue heal and in order to have more volume, of course, but just this surgery is extremely challenging, and I do not want to show you how good am I in surgery, because I think all of you can deal, but it's extremely complicated, and sometimes you have to go, you have to do, and to try the solution with the best technique in order to anticipate more or less the best result. And Anton Sculean is extremely right. It's not only a question of surgeon or to go and to place the incision, but this flap design was, that's why I chose this flap design. And because of it was already described in the literature, this papilla amplification flap, because by doing that, by doing the submarginal incision, you can elongate the papilla. And in this case, you can go, of course, after removing, you could see that how thin and how maybe still inflammatory, even if the patient had a very good plaque control, was inflammatory. Of course, I think the best is not to go right after. But if you deal and the patient wait and you have this result, how to deal with that? Because we are in an everyday clinic, how to deal with that? And the best, according to my knowledge, and my surgical knowledge, the best way to deal with that, it was to go for this flap design, which is named the papilla amplification technique, and to elongate the mass as much as possible in order to go to anchor palatinally this flap interdentally.
Okay. Thank you very much, Sofia, for this kind of specification of the design. I'd like to move on because we really need to see. I'm really curious about what are the next steps, because so far we talked about the approach. Now, Mark, I would like you to go on with your case and how you kind of elevated then the flap in your situation.
This is now the major part of the surgery. You see, you have to split the palatal tissue now with a thickness of 1.5 millimeter. This is not so easy, no doubt. We have today special instruments available, a new blade designed by us is coming on the market now, which allows you better to do this kind of surgery today. But this is the tricky thing, to create now a split thickness flap here on the palatal side, splitting the palatal tissue thickness in the middle and reaching about 1.5 millimeter thick flap, which you later on then can move coronally. This is the major problem, that we need, as everybody is now discussing this issue, we need coronal positioning. We need mobilization in the coronal direction, and this is the major problem, which you have with the tunneling technique here. There's no doubt about that. To overcome that is not only that you split, because afterwards you have to split from the base of the flap in the other direction coronally, so the tissue will move coronally. So let me share this with you briefly. Can you come to me here? And I need you as a moderator here for a second, that you understand better what we are doing here. When we look at me, I am the tissue over the bone. You are behind me.
Oh my God.
So look at this. The moment,
that was not in the script.
The moment you bring volume here buccally, like this, you see, you get more, this is buccally here. The moment you bring tissue, you flat here the papilla. Therefore, you need to hold my feet here and bring both up, So you need to bring the tissue here on the palatal side in the height, and now you have height here without flattening the papilla. And that's exactly what we are doing here. And that's exactly described here now, that we are able now to bring the tissue in a coronal mobilization with this approach.
Okay.
Now they understand better.
I will never forget that.
You see?
Okay, let's go on.
Thank you very much, Mark and Ronnie, for this excellent demonstration. I already was waving to Sofia. No, we're not going to do physical demonstrations. But please go on and show us your videos, how you prepare the flap.
Okay. Let's see. Therefore, you can, now we are elevating because we already are done with the submarginal incision, and you can now see that we are elevating at this level split thickness papilla. I think Mark will be very sick now because he's observing that we split the papilla, leaving really the connective tissue graft underneath. And of course, the flap elevation, it will be full split according to the description of the original technique. And now, of course, we are extremely carefully around the implant and creating, and when you see that all the connective tissue that is remain in situ will be kept there. because we only remove the epithelium. And of course, we are extremely the elevation, extremely carefully, because we know that in order to advance in a coronary position, we have to pass beyond the mucogingival line and around the teeth and the implant. The dissection is in full thickness manner. And we go very carefully. You can see that the incision is oblique in order really to leave the periosteum at the level of the incision. And believe me or not, it will disappear. You won't have any scar tissue, only just to pay attention to that, how you incline, or you put oblique your instrument. And now, of course, it's extremely difficult because this patient underwent several surgeries before this mucogingival surgery. And extremely difficult. The tissue are not thin. You can see that there are, but it's extremely difficult to detach from the bone surface the tissue. Therefore, you have to be extremely careful for that in order not to preserve the integrity of the flap. And we go very nicely. You can see that the full thickness part of the flap, it will be positioned coronally, covering completely the connective tissue that remain in situ. And we pass beyond because, once again, the goal is really to detach the muscles. You can see now the position of the flap. We are doing the first incision in order to have access to the inner part of the flap and to detach very nicely. And the blade is positioned parallel to the inner part of the flap. And you can see that I am doing that with a 15C blade. Why? I'm not using microblade. It's very fun to use that. But me, I really want to feel the tissue really, and in only way to feel it is to work with this 15C blade. Of course, I use also micro tiny blade, but for this kind of dissection, I always pass. And you can see that little by little you gain somehow the passivity of the flap.
All right, thank you for sharing, Sofia. Ronnie, back to you, but not before I let you know that Stefan Beans is saying this is the best explanation ever, Markus, on your little acrobatic act there. So back to you.
Thank you very much, Sofia and Gerrit. I was also hoping to see some gymnastics in Paris, but that was not the case. So, Martina, when I saw now the flap preparation of Sofia, I think that's really a very important step, maybe the most important step in the whole procedure. How do you explain this?
I don't have any yoga position to explain this the full split thickness approach, but the idea is exactly what Sofia told us, is to elevate the flap when it's possible, full thickness, to keep the periosteum inside the flap, in the portion of the flap that will cover the avascular area when you will coronally advance your flap. And then with the deep and the superficial split thickness, you will be able to remove all muscle insertion, because the key of the coronally advanced flap is to remove all the tension, because at the end of the surgery, your flap will remain stable in the final position without any tension. You don't need to force it with the suturing technique, just.
So to understand, I do first the split flap.
The deep split thickness incision with the blade parallel to the bone.
Yes.
To detach the muscles from the periosteum. And once the alveolar mucosa is detached from the deep insertion from the bone, you can change the angulation of the blade and become superficial to detach the muscles from the inner aspect of the alveolar mucosa, which is elastic and without any muscles can be coronally advanced, whatever you like.
Very good. So now we need to see how this goes on. It's kind of really exciting because we prepare the stage, and now Mark, the stage is yours again. After gymnastics, I'm getting insecure what else I need to do now during this, this debate. But now I think next step is harvesting the graft.
Next step is harvesting the graft. We choose here the tuberosities around implants. We like to harvest the connective tissue, the total connective tissue always in the tuberosities because we need long-term stability. This is now more internal evidence. I mean, this is a topic we can discuss. I'm sure we have a lot of discussion here maybe about this topic, but in our hands, in our cookbook, we have defined in our clinic for implants where we need a lot of volume because the deficiency is most of the time very big, we like to choose the tuberosis graft. How to harvest it? Today we like to harvest similar like a distal wedge preparation in the perio, but today we do more and more parallel incisions to harvest as much as possible. This gives us more graft. The more you have, the better. You can trim it later on the glass plate or whatever, but harvesting always as much as you can, and then you can deal with it and fit it and trim it to the site.
Do you go actually just to the sulcus of the last molar, or what is the distance then to the sulcus there?
No, we always harvest the tissue till we take the sulcus with us always. We take the whole tissue, what is possible. So distally of the last molar, we cut the sulcal incision, and then from there we go today parallel. And a good tip is today we go 6-7 millimeter over the mucogingival junction, over the so-called R-line, that we can close afterwards the flap easier. The more you go into the mucosa there, distally, in the tuberosity area, the easier it is to get mobility in the flap. The more you harvest, the bigger is the defect, and then we bring them easily together again.
So it gets still more exciting. Now, Sofia, what do you think about this tuberositas graft? What kind of graft have you harvested now in your case? And how did you harvest the graft on the palatal side?
Yes, please share with us, Sofia, how you harvest the graft.
Yeah, in this particular case, the graft was harvested from the palate with the single incision technique described by Markus, by the way. And because in not all the cases, because of course, whenever it's possible, also I prefer to go to harvest from the tuberosity. But in this case, it was not possible. Therefore, I choose to go for the single incision technique, as you are now observing, that you have to pay, of course, you have to pay attention to the anatomy of the palate in order to angulate the best of your blade. And now you are seeing that we are parallel to the inner part of the flap, the palatal flap, in order to leave as much as possible the connective tissue that it will be harvested. You could see that my patient, the patient that was operated had a thick phenotype because of the several surgeries that she underwent. And now I need really, what I needed to support is the interproximal area of the central incisor. And leaving in situ the connective tissue graft, thanks to the submarginal incision, I think I thought I have enough connective tissue in order to support marginally in a new coronary position the flap. That's why I harvest this size of connective tissue that you will see that it will adapt very nicely to where I need is around, mainly around the central incisor. Now you can see that, of course, you use the blade very, very often in order to get the desired size of the connective tissue graft. And you can see that we obtained, because we were lucky, the patient had enough connective tissue from the palate, therefore we could harvest the desired size of the graft that we needed in order to place around and to support the interproximal area of the central incisor, between the central incisor and the implant.
Wow, thank you for sharing, Sofia. Back to you, Ronnie, to discuss and reflect on these two approaches.
Thank you very much, Sofia and Gerrit. Now I would like to talk to Tony. Now we have seen these two different approaches, two different grafts. That's, for me, now confusing, because my aim is still that I know next week, when the patient comes back, what technique I should use. Now, as a university professor, give me a little bit of background regarding the science behind the different type of connective tissue. What is your approach?
If you want to have a graft that is stable and it maintains the volume on a long-term basis, for example, if you would like to augment the side, a pontic, or maybe you are dealing with an implant, then definitely you should go to the more posterior areas, because there you have a more collagenous graft. The more anterior you go, you will see that you have more fatty tissue, and probably the stability of the graft is not the same. However, we have to decide what kind of indication we have. If we are dealing with an implant, you want to have a volume augmentation, like it is the case of Mark. Definitely, I think it's the right approach to go more posterior. I mean, this is the case. If you are dealing with a case like Sofia, where you have, let's say, even 3 recessions because it's a large area, I would have preferred to go maybe from a distal area to start from the number 8, and I make my incision until the central incisor. I like the big stakes, you know. So, but this is my approach, because I think that if the graft is too little, then you have maybe the problem that it may disappear, or may shrink, or whatsoever. You have to take into account maybe 40% of shrinkage as well. So I think the harvesting technique is okay. Of course, we can also discuss the issue whether we harvest a free gingiva graft and then we deepitalize. However, since I don't have microscopic eyes, I don't see the red apex, but maybe in other countries is another point of view. I mean, you can see the red apex, but in Bern we don't have that good visibility. However, I prefer to use the single incision technique, definitely.
Okay. Martina, what would be your
Tony
approach?
decided that we wanted to confuse you a little bit more, introducing another harvesting technique, which is the free gingival graft technique. And the reason why I prefer this technique is because of the quality of the connective tissue that you can harvest, because it's the immediate subepithelial one. And differently from the tuberosity graft, you have less risk of hyperplastic reaction, because with the tuberosity, from some histological study, we know that you have the risk to have some hyperplastic healing. And at the end, you will have true thickness in the buccal aspect of your patient. Because another aspect that we should debate is how thick we need the graft to treat the implant. And from my point of view, we need between the flap and the graft to reach 2 millimeters of thickness, no more, because otherwise you will have too much thickness, which is not nice from an aesthetic point of view.
So let's put the graft now in place. And Mark, I would like to see how you place this graft.
This is a lot to discuss what you said.
Try to focus.
I disagree completely.
Try to focus and tell me why you have harvested that type of graft, and whether you have concern that you once have maybe too much volume in this area.
I mean, I ask, if we don't have it with a free gingiva graft deepitalized, why we have a publication saying that 12 out of 25 patients had hyperplastic reaction. There's a publication coming out from your group saying that. So you don't have...
No. It's not a hyperplastic reaction. It was graft exposure due to flap shrinkage. So if the flap shrinks...
You had keloid.
It's keloid because of the flap shrinkage, not for the characteristic of the graft.
But then you have still at the end keloid. That's what you described.
If the flap shrink, because we were comparing two techniques in a randomized way. In one technique, we remove the muscle from the flap, and the other no.
But when you have 25 cases and 12 out of them show problems.
But the problem was not related to the graft, was related to the vestibular technique, to the flap, not to the graft type.
So the longer it even gets, the better the debate becomes. I think we need to quickly see the video again, if that's possible, because we kind of were too much debating and not looking in particular how the
We
best
have
actually plays.
actually, what we haven't seen now is the
Marcus, we need to learn how to do it. So tell me what you do here.
What we are doing is we remove 1 millimeter of epithelium. When we use a tuberosity graft, we use always 1 millimeter because we have the same problem like Tony. We have done some histology looking when we remove the epithelium, how much epithelium we leave back when we do a depigmentization of a graft. And when we remove 1 millimeter, we are on the safe side. We always turn the graft with the epithelium side against the bone. So we do this very often using this technique. Now we are in an area of internal evidence. This is a problem from tonight we have anyhow, that we don't have a lot of evidence. We speak a lot about our internal evidence. And our experience with this approach, I can tell you, we have one case where we have a plastic reaction. We do this on a daily basis. We don't see this problem so much. But this is, again, a little bit of...
Mark, I need to know what you do.
What we do. Now we do helping suture. These are helping suture, the white sutures. We now create, these sutures are only there to bring the graft into the tunnel. They will not stay there. They will taken off later on. They help us now to bring the graft in the position where we want to have it. Supporting the papilla a little bit to get tissue in underneath the papilla, also interproximally, buccally, everywhere we want to have it. We can use those helping suture, or we call them also positioning suture. We can move those, this graft with this helping or positioning suture into position we want to have.
That's why you cut it as well into kind of like two parts to kind of have one.
It's not two parts. We cut it in the middle and open it and have therefore now...
A V shape.
Yeah, a V shape or butterfly design, some people say. It gives us, you see, on both sides, we have now the tissue. So we have enough tissue to support also the papilla to get volume in the coronal direction. But I don't say we augment the papilla, and we'll never say that. We cannot do that on a predictable base. If this happened, we are lucky, then we are proud, but this is not predictable. When we discuss here, we should always discuss predictability. We should be 95% predictable when we do a plastic reconstructive surgical procedure, the aesthetic zone. 95% is what we need to achieve. If we don't achieve that, if we don't know beforehand, in our opinion, we should not do it.
Are you now concerned about Martina's comment that you might have too much volume in this case, that it does not look aesthetic when it's too much? Because I do agree with you, it can also be too much.
Since I'm doing this, as I said, since more than 20 years, I have one case, I agree. We have one case in all our cases with hypoplastic reaction like...
You have done 3, and from there, 1...
We have done 3, yeah.
Okay.
And Gamborena describes and shows, and Uli also shows, but honestly, we have one case in all our cases, and I do this every day. I do harvesting tuberosities for implants every day. But again, I agree with Martina, this is the problem we have. I told you this from the beginning. We have not enough evidence in anything what we are discussing right now. We could see that Sofia took the graft not in the premolar area, she took it more distally, so therefore she had a little bit better quality. If you take a subepithelial connective tissue graft in the molar area, you have even there already a higher quality of tissue. If you take a free gingiva graft and depigmentize, you have even a higher, then you get more stability, but this we don't know. We are here, this is assumption from you, from me, from you. We say, okay, we take tuberosities, then we have more stability. Where is the proof? We have no proof. There is no volumetric analysis over whatever years showing us that this is what we are here hypothesizing is true. And this is something we need to tell our participants too, that yes, our experience, we are here, we have very experienced guys, and Sofia, that tells us we are more stable when we use that, but the scientific proof, I would say personally, is missing.
Okay, thank you very much, Mark. I would like to hand over to Paris again to Gerrit, because we want to know how Sofia has really placed the graft and what was her thoughts behind that.
Exactly, and it's clear this is a hot topic because you have people jumping in seats. I have Sofia every now and then wanting to jump in all the way to Hamburg, but we also decided we wanted to guide you, Ronnie, in these 5 steps in the surgery. So it's now time to go on to the next step. Sofia, can you share with us how you place the graft?
Okay, sure. But just I wanted to add something very, very, very quickly, that we are talking and hypothesizing a lot of things, but we have to face the real clinical situation. And maybe I am unlucky because in not all the cases I have the possibility to harvest from the tuberosity. There are a lot of situations where you cannot, and you have to absolutely adapt your surgical technique and your surgical knowledge to the clinical situation. And that's why, and Markus saw very well that I harvest my connective tissue grafts from the most posterior area that I could in order to have dense connective tissue.
Exactly, that's where you harvest it. Let's see where you place it.
Exactly. And now we will see that my main concern, as I told you before, it was that to place the connective tissue graft around the central incisor and also somehow interproximally in order to support the elongated papilla, the surgically elongated papilla. And you could see that, of course, I remove the epithelium and I left, you can see much better the epithelium left on the cuspid and also over the implant, what I left in situ. Now, of course, I am placing a simple suture in order to fix the connective tissue in the mesial aspect, and afterwards I came from the palatal aspect interproximally. I take the connective tissue graft, going back through the palatal papilla, because the palatal papilla was not detached. I just remove as much as possible. You can see now very nicely that I pass through the palatal papilla in order to have interproximally connective tissue in order to support the flap there where it was needed. And you can see that the flap is extremely thick, and I thought that we are not need to support much with connective tissue graft that part as well, because it was enough. You can see that it was placed where I wanted that it be placed.
Exactly. Well, thank you for sharing that. Now, Ronnie, before I hand over to you from the last time and for you to finalize this conclusion in the next 10 minutes, I want to read out 4 quick responses. First of all, Mariano Rocuso writes, he was one of the debaters on Monday night, please mention how important it is that the position of the implant and not all dehiscences can be treated, which is very related to a comment from Iva Milinkovic, who says, at which point do you decide that it's not reasonable to treat an dehiscence or aesthetic failure around an implant? Then Nada Zazu says, I agree with Martina's approach and greetings from Egypt. And finally, Afonso Gil wants to comment that he finds it an amazing session, but keep in mind that the predictive factor, as a predictive factor, how important it is that the final position after suturing of the peri-implant mucosal margin. Now with that, take it all in your lap, Ronnie, and I wish you good luck finding out what you need to do tomorrow.
Or on Monday.
Thank you very much, Gerrit, for the good comments, and also thanks for the good comments from the audience. I think they're really supportive, and especially the first one regarding implant position. And this was what we mentioned at the very beginning, that the main thing is not the surgery per se, the main thing is the indication for the surgery and assessing the case. But now we would like to move on and would like to see at the end how you have sutured the case, because we have now seen how you place the graft, and now I would like to see how you manage to really come coronally with the sutures, because I have seen it, how we did it together, but now I would like to see whether the flap really was positioned coronally. And don't ask me again for any gymnastics, just show me now here.
But they liked it, okay?
So here we have now in parallel, in order to save time, Sofia's approach and Mark's approach, and I think we just comment now on Mark's suturing there. And maybe Martina, you can give a little bit insights regarding Sofia's approach. Mark.
So we created two anchors between the teeth. We add some composite there, a drop of composite between the two teeth. This is our anchor, and then we do the so-called double cross suture, which uses this anchor as a stabilization. You can move with this suturing technique the flap in a coronal position, as you will see, when you have created enough mobility to the flap. The mobility we already demonstrated together. So that's what we do here. This is published, this double cross suture, in the Journal of Aesthetic Dentistry, and also in our book. You can read it. It's a little bit complicated. When you see it now, we can hardly go through this technique now, but you will see how the tissue moves. I would say what we are doing is we place, as a surgeon, the papilla in the best biological position what we can. That's what we are doing. We help Mother Nature for the healing, that she can heal in a more coronal position. That's the idea of these suturing techniques. We use here a 6-0 suture because we are allowed to give a little bit of tension. There's not a lot of tension because 6-0 will also break when you give too much tension. This is our guidelines, I would say. If it's too much tension, then 6-0 breaks too. But this is what we are doing, how we stabilize the graft.
Martina, maybe you can comment on Sofia's case.
Yes, now Sofia, I'm speaking on behalf of you, Sofia. And she's closing the flap, and she started at the level of the vertical releasing incision, because the idea is to start gradually reducing the tension of the flap once the flap is in the final coronal position. So with the tweezers, she placed the surgical papilla above the anatomical papilla, and she closed the vertical releasing incision. And now she was performing the sling suture suspended around the cingulum of the included teeth that simply obtained the tight adaptation of the surgical papilla above the anatomic desepithelialized papilla. And this was the topic that we discussed before, that for the coronary advanced flap, we need to have the blood supply from the anatomic desepithelialized papilla. So in this case, probably if we will have the chance to increase the quantity of the interproximal tissue, reducing the abutment, removing the crown before the surgery, this will help the stability of the flap in the coronary position, because to obtain the stability of the flap, you need the vascular supply from the anatomic desepithelialized papilla.
Thank you very much, Martina, for these comments. Maybe I would like to hand over quickly to Paris in order to get the inputs from Sofia regarding, just in a few sentences, how you would comment on your suturing technique, and what is something which when I would like to learn this and would like to apply this, what do I need to know about that?
Just, I think Martina explained very well. What is the most important thing is to prepare the flap in such a way that passively you can advance, and the sutures are there in order to fix in the right position, to stabilize that, and not to pull the flap. And it is extremely important, of course, when you open the papilla, because now you could see that we open the papilla, that of course, you go through the palatal papilla in order to close very well and to get the stabilization of the clot. Passing through the palatal papilla. And of course, and what is extremely important is maybe a detail, and Martina also mentioned that you start from the releasing incision, and also the position of the needle is extremely important, because the position of the needle is oblique, an apicocoronal direction, in order also that advance in a coronary position and make even more passive the adaptation of the marginal part of the flap.
Well, Ronnie, I hope that clarifies for you.
No, that was important. Thank you very much, Gerrit, and thank you very much, Sofia. So now we have completed these cases, and I think there are still a lot of issues to discuss about. I would like to ask Tony now, coming back to the original indication. In these situations, we have seen two cases. Would you have done another approach, or would you have exactly chosen the approach Sofia has done in the more advanced case, I would say, and in the case where we don't have that much of volume deficiency as we have seen it in Mark's case, that he would have gone there also for a tunneling technique? Or what would be your approach to these two cases, I would say, because we cannot compare them?
You're perfectly right. I think that definitely in the first case, Markus' case, I would go for the tunneling approach. I wouldn't adopt exactly the same surgical technique as he did, but somehow I would have tunneled, maybe intrasulcularly from the neighboring teeth, and then try to go also under the papilla because there was some space interproximally.
Would you have removed the crown? That's for me also an important topic which we might address later on, but would you have removed the crown?
If I would like to focus only facially with the volume, I wouldn't remove the crown in that case.
And can you do the technique you have described without removing the crown?
Yeah, you can, but then it's very difficult. But this is something we need to discuss because you have to create a new emergence profile, because most of the time our implant reconstruction have the wrong emergence profile. Then you can be the best surgeon. As a prosto guy, you know right away it's convex. What do you want to do? You're going to be the best surgeon, whatever, you will end up with the same recession again. So we have to remove the crown and create the perfect emergence profile for an implant retained crown in the aesthetic zone. We all know how it should look like, and then we can do a surgery to it. So that's why we do a new long-term provisioning on a crown like this, where we decide to maintain the implant, and then we do the surgical procedure to the perfect emergence profile.
Of course, but this is what I meant. I mean, I started from the very beginning with this. First, you need to have some temporaries with a specific slender design and concavity, because otherwise you don't have any space for a connective tissue, and you cannot stabilize the wound. It is just impossible.
But now,
definitely, you need this temporary.
From a provocative point of view, to make it simple, doesn't make my life much easier when I just remove these crowns, let it heal in all cases, and just going to make a connective tissue graft in this edentulous area, make a very minimal invasive abutment connection, and then start to condition the soft tissue again. Martina, wouldn't that be the easiest of all the ways? Why kind of making gymnastics around the crowns and doing kind of another emergence profile? Just get out of the crown and make it easy.
But again, it depends on where is the gingival margin position with respect to the adjacent, because if you let everything heal, but you need to shift in a more coronal position the gingival margin, it will be not enough after the maturation, after the healing. So you need to coronally advance the flap in this case. If you have an easy case in which you have simply to increase the thickness of the tissue, you can perform a tunnel, and for me, in some cases, you cannot even remove the crown. But I use the submerged approach when I want to increase not only buccally, but only the apical position of the interproximal tissue. In these cases, I go through the submerged healing because I can increase apical coronal, also the interproximal tissues. But this is for advanced case, not for easy case for me.
But
in my
honestly,
point of view.
Ronnie, honestly, this is not an approach. If you start, this is not an approach. If you start now again going back to this old-fashioned way to create emergence profile by adding to see the patient. Now, what you are doing is seeing the patient every 2 weeks, adding a little bit composite there and there. Once you have, you open, you let it heal, and then you place the connective tissue, and then you start to rebuild. That's what you're doing. Then you start to rebuild the emergence profile. That's what you're doing.
But not
That's what you decide, what you describe.
Yeah, I was just asking whether we should do it that way.
Yeah, but this means, you know, the patient. This is the 5 o'clock evening patient on Monday night. Every 2 weeks, the patient comes in, and you add a little bit there. That's what still is, for me, sad And I think the results are not so predictable than it's said. I think the surgical approach, that's what we really today try. We do the surgery to the perfect emergence profile today. This is a completely different approach. This is a different thinking. This is a completely different patient management approach. The way people recommend, in my opinion sometimes, we have done also 10, 15 years. And Otto, my partner, likes to do that in the evening, 5 o'clock, to add and work and try to get the papilla and so on. We have tried this, believe me, but we were not so successful in the predictability.
Yes, but I think that's anyway, would be another debate, because I think the emergence profile of today's crown looks completely different than they have looked 5, 10, 15 years ago. So I would like to wrap up with what we have seen. I think it was a wonderful topic about having a debate about, but I need to summarize for myself and for you, ladies and gentlemen, in front of the screen. We started with actually 2 different situations, and I think we should keep in mind, number one, we need to assess the case also regarding the implant position. And there are cases which I think we all agree, which we cannot do anything there. We need to maybe even be invasive and remove the implant and start from scratch. That can also be the case. So we need to have a situation where we have an implant which has at least a proper implant position. As a next step, we need to assess how much we need to coronal advance. And when we do have really a significant coronal advancement, we might consider going for an incision on the buccal aspect in a coronally advanced flap. I do have to say, technically, it's kind of definitely a little bit more risky, because you need to really know how to adapt the flap in this area. And you can end up by having then papillas, as we have seen in the beginning in your case, where we really have some unnicely soft tissue situation. Whenever I can, I think I would say the tunneling technique I like, because it at least I don't need to cut through the papillas there. So also when I'm not so advanced, then I might not end up really in a very difficult situation. Tony, do you agree on this assumption?
Yes.
What do you kind of that we need to customize the indication according to the situation?
I think the most important point is to decide whether the case is a case that you can improve or not, and whether this case can be improved with soft tissue surgery or not. And then the rest, I think, is very important to mobilize the flap or the tunnel. In other words, the flap or the tunnel have to fly without tension. And whether you cut or don't cut, I think it doesn't matter so much. I mean, I prefer the tunnel, but at the very end, you have to have a tension-free mobilization of the soft tissue and the perfect suturing in order to keep the wound stable, to stabilize the blood clot. And then, as Markus very right pointed out, the Mother Nature will do the rest. But we have to help with all these steps the body to heal. And then the defect will heal by itself. As simple as that.
So as a last word, Martina, ladies last, what did you like most about the debate today?
I like the gymnastic, the gymnastic exercise.
I was thinking there. So I think we have learned a lot about dealing with the problems in the aesthetic case. I think, again, assess the case properly. We have multiple options in terms of flap access. We have multiple options in terms of the grafting and where we take the grafting. I think we have learned a lot. I feel more confident, but again, I think that's not enough, obviously. So it's fun to be dentist. I think we have still a lot of things we need to kind of make it even better. And with these exciting words, I would like to give back to Gerrit, to Paris, and would like also to thank Sofia very much for being with us in Paris. It was a little bit more difficult, but I think it worked out excellent. Thank you very much.
Thank you, Chair Ronald Jung, and your experts there in Hamburg for this very exciting and insightful exchange. And many thanks to you, Sofia. But before we go out, if you've been listening and sitting here to this whole debate, if there's one thing that you take away from this, what would that be?
That the discussion was extremely interesting, but just let me add just something.
She's jumping off her chair, Ronnie.
Really, we have to, just a little bit, we have to keep in mind that the thickness of the surgical papilla The surgical papilla, therefore when we elevate the papilla, the thickness of that is 0.8 or 1 millimeter. And that is less than the 1/5 of the entire body of the papilla. And
In this specific case, you mean?
Yeah, but normally. Therefore, I think I am doing the tunnel technique, and everyone knows that how I love much the tunnel technique. But there are, as Martina told several times, when you need to advance and to place in a coronary position, and you have to deal sometimes with this complex clinical situation, you have to rethink a little bit all the steps of the surgery.
Exactly. You have to deal with the clinical situation. That's your message. And that's
Exactly.
why we invited both of you to have both these surgical techniques side by side. So thank you for being with us here in Paris. And thank you for your very active participation and contributions here online. Now, like every night at the end of this primetime debate, I invite you to briefly reflect on what you have just heard and mainly also seen, and share your thoughts with hashtag EAO Digital Days on Twitter, Instagram, LinkedIn, or perhaps straight into our EAO Direct Facebook group.